Good afternoon. Welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stein. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. With me, as always, Adam Thacker, who's our Chief Operating Officer of Good Samaritan Hospital. He's also one of our pharmacists, and hopefully he'll handle all the difficult questions on the new drugs we'll be discussing today. Kind of leading off, we talk numbers always, so a little bit over 8,000 cases since we began, but really the issue right now is positivity rate. And we talk about that every time. But a lot's happened since we had our last program. Certainly we have been through holidays, we are in our normal cold and flu season, and we're seeing rises, but the dramatic rises that we have seen are like nothing that we've seen throughout the pandemic so far, and that is positivity rates for all around 20 and for unique individuals over 40%. But something we discussed earlier was our own in-house lab positivity rate is over 57%, which is like nothing that we have seen yet, which really speaks to the state of the union as far as our local condition.
Right, and as you mentioned, 40% being reported, one of the highest numbers that we have talked about. But what that tells us is that number is yet to hit its peak. We're continuing to climb. First time our lab's reporting over a 50% positivity rate, and yes, this is the Omicron variant by all indications. Indiana now reporting over 90% of all cases are Omicron. So you get this, we've dealt with throughout the pandemic, this kind of first news becomes the truth is that Omicron is much more transmissible, but you won't get very sick, so don't worry about it. The concern with that is that it's a little Russian roulette with how sick you will get. It's absolutely true that it's more transmissible, 4 times more transmissible than the last variant, Delta. And it is showing that there's likely less virulence, so less severe, lower hospitalizations, because we're seeing numbers just climb and climb and climb, but the hospitalizations, while they have bumped up, not seeing quite the severity of illness. And we'll dive more into this, but as we talk about that vaccination status and having on board initial protection versus unvaccinated, those coming in contact with Omicron are still at a high risk of severe illness, hospitalization, and long-term effects that we don't even know about yet if they are unvaccinated.
Yeah, and that speaks to the big issue, which is the healthcare system itself, where we're at with things. And the challenge has been during these times of peaks that the resources get gobbled up. Hospital is full, testing gets limited, resources as far as treatment get limited. Thankfully, the hospital, although we have had a full house for 2 years, the good news is things haven't been as bad with this last variant, but the problem is we have so many more people that have contracted it that even if that percentage of people that get more severe illness stays about the same, we get more patients in the hospital. So that has become one of our challenges. So certainly we are still encouraging people, if you have received your full vaccination status, which is your initial vaccine, your booster, or your initial vaccine, your second vaccine, we recommend the booster, because what the studies have shown now is that initial vaccine and then your second shot after that is not performing as well against Omicron until you've had your booster.
Right, and unfortunately we somewhat predicted this as we were working through different variants emerging. Vaccine efficacy becomes the first and foremost discussion when there is a variant. And we talked about spike protein and mutations. And those initial variants, the spike protein didn't change, and that's what the vaccine targets. But this Omicron variant, there were 34 changes to the spike protein, and it makes the initial vaccine less effective, but there is still effectiveness. So if you're in that, I haven't made the decision to get vaccinated at all yet, it doesn't mean don't go through the steps to get there. It is still far and away the best preventative treatment that you can get, and we'll talk about other treatments. But that booster gets us back to that 80+% reduction in hospitalization and severe illness. And as you talked about, that's what it's about, is staying out of the hospital. Some of the national reports from infectious disease experts have said Omicron is so transmissible that nearly every single American that's not living by themselves in a shack in a mountain is going to come in contact with Omicron. The difference is early protection on board through vaccination, may not even know you have it, to have very minor symptoms, runny nose, feels like common cold, to those that end up in the hospital.
And this is somewhat the perfect storm. We talked about this before holidays, but from the time that October hits until we get through cold and flu season, which is about the end of February and March, this is when we spread all of our bugs and germs around anyway. So the fact that this has hit and is spiking now is sort of the way that we expected things to go. The unfortunate thing is the transmissible nature of this is such that it's just exploding much faster than what we've seen with the other variants. Now, the thing that is somewhat difficult for the public is the fact that when we look at big news media and other places, they've had their Omicron spike. And East Coast, West Coast, down south, they've been up, they've been down, and you and I have seen some of the recommendations coming out of our bigger federal agencies. And unfortunately, a lot of that, I think we believe, is because they've been up, they've been down, and here we are in the Midwest, and we've started our trek up, and it's pretty sharp right now. What we want to know is it going to last 2 weeks more? Is it going to last 4 weeks more? That's kind of where we're living.
Right, that width of the curve is really important, and as you look back at prior surges, there have been some that have stretched out 5 months to the most recent one was about 2 months, and we're a month and a half or so into starting to see Omicron pick up. But again, that transmissibility. I also think that there is a general feeling to some degree of I'm over it, we're just going to deal with it. My cautionary advice on that is when we look at resources, going back to that, 8 out of 10 ventilators in Southwest Indiana are in use today. We are a little bit more than that, actually. We are just under 20% of ventilator availability. And while that may not resonate because feel healthy and otherwise might not we have unfortunately seen many healthy individuals that have ended up with serious illness. So it kind of gets back to the Russian roulette of I'm going to gamble with this, and as we all know, when you gamble, sometimes you win, sometimes you lose.
And one of the things that unfortunately I think has compounded this is a little bit of common sense has been sort of throw caution to the wind around the holidays and immediately afterwards. And that's because we kind of got lured into a little bit of sense of security. Things weren't going too badly. Pre-holiday, things were looking pretty good. And then, as expected, we all get together and do our social events, and things take off again. But I think, like you said, again, we're still encouraging people to make sure, and if you haven't been boosted, please get boosted. That is tremendously protective, and again, takes away some of that burden to the healthcare system and protects those individuals. Fortunately, over the last year or so, we've been very fortunate that resources have been good. Testing has been readily available. The treatments with monoclonal antibody have been readily available. The challenges really have been in the last few weeks or so in dealing with the fact that testing availability has dropped and the available treatments, although there are new things that have come to bear in that meantime, the availability of monoclonal antibody has dropped. And so our messaging today is going to be a bit different because in the past, get out there, get tested as quickly as possible. High-risk people need to get in contact with providers, be seen, and get right in so we can get you treated with monoclonal antibody. And that's changing a little bit.
It is, and when you talk about that sense of security or that security blanket, you can quickly go out and find articles on new treatments that have emerged for outpatient protection against COVID, but the availability of those is a significant rate limiting factor, and as well as that initial testing, and so we were performing rapid tests every day, 20-minute results, and able to meet the needs of anybody who needed tested. And just this week, we had to look at our convenient care model to say, how do we add more resources to that, because we can't test the number of people in one day that need to be tested. And that has happened in a lot of areas in the state, and I've been very proud that we have not had that. We have been able to test people when they wanted to get tested. And I know I say that from the COO standpoint, which means you may have to wait a couple hours, but I'm comparing that to some other areas in the state that we talk to frequently that our couple-hour wait is days wait, which in essence sometimes puts them even outside of a treatment window. And so now we're also looking at when we do have sick individuals, we are having to be very restrictive in who's at the most risk for being hospitalized and try to keep patients out of the hospital as much as possible.
The one thing that we haven't really addressed or specifically recommended in the past is who shouldn't get tested. But I think one of the important things to realize right now is there are individuals that really testing is not going to do much or change much. If you have had contact with individuals who are positive for COVID or have symptoms, and you develop symptoms, and you are young, otherwise healthy, not with a lot of risk factors, you can presume that you have COVID, that you are positive, and you should isolate as appropriate. There is absolutely no reason for asymptomatic testing at this point in time. That gobbles up resources that we need for other individuals. So if you do not have symptoms and you've had contact with somebody, there is no reason to go out and get asymptomatically tested. One of the other things that we're struggling with a bit is different workplaces, schools, and otherwise are suggesting testing to return back. That has never been, nor will that ever be, a recommendation for a variety of reasons, because that in itself does not necessarily mean that you are contagious, not contagious, spreading virus, holding on to old dead virus. So asymptomatic testing, not recommended. Testing and return to work, not tested. Any other ones that I'm missing that we would discourage people from gobbling up those resources?
Those are certainly the two large ones, the asymptomatic group and return to work. And that asymptomatic group exposure, even in those groups that are concerned that they're higher risk, we would advise talking to your provider, having a conversation. What is the risk? Should you get tested? What we know with this newer variant is from that initial exposure, it's also our rapid tests in particular are not as sensitive if you're asymptomatic. So we call, you hear the word false negative and you immediately think, well, the test was wrong. But false negative is the virus actually wasn't present. And so at that time, you're getting that, again, that sense of security that there is a negative result. You don't have COVID. Well, and then you very well may down the road.
And so what this is all boiling down to is the available treatments that we've had previously with monoclonal antibody. We gave thousands of doses of that over the course of the last year, had great success with that. However, against the new variant, unfortunately, the previous monoclonal antibodies that we've used, it's just simply not as effective. So the newest monoclonal antibody that we are using is effective, but the quantity of that is available has been tremendously reduced, whereas previously we were administering that anywhere from 10 to 20 times per day. We now have availability to give maybe 1 to 2 doses of that per day, and that is now being focused on our highest risk patients.
Yeah, as you mentioned, we were getting on a 2-week allocation shipments in the hundreds of monoclonal antibody treatments, and now it's in the teens. And the pressure that, as we talk about that surge kind of continuing to climb, the continued pressure that it is going to put on being able to identify the highest risk individuals is more and more, and it's a national issue. We have seen positivity rate go up, the number of individuals that are testing positive go up, thus the number of high-risk individuals are going to be identified, yet our treatment options where we had 2 or 3 monoclonal antibody treatment options went down to 1. Now what we have done is started to look at other treatment options. And so remdesivir has been a drug name that you've probably heard very early in the pandemic, and we've continued to use that for hospitalized patients, has now been approved to use in the outpatient setting. It is a similar infusion to monoclonal antibody, but rather than one time, it's given 3 days in a row. And then we also have some oral treatments available. Paxlovid and molnupiravir are both oral treatments that are available, but there is a algorithm that our clinicians walk through to make sure that individuals are appropriate to receive those treatments, because at the end of the day, we are talking about drugs that are being given to treat a virus, and so we have to make sure that baseline, first and foremost, that we're doing good and certainly not harm. And I'll put the plug in again because, one of the, I think, ironies of the pandemic has been that everybody has become an expert on treatment and what treatment I should receive. And I urge people to trust the medical professionals that are telling you vaccination is the preventative, safest, best avenue to take. None of these treatments that we're talking about replace being vaccinated, and they shouldn't be viewed in that way. And the conversation of I'm not going to get vaccinated because there's these treatment options, I assure you the 400 million plus doses of the vaccine have been much more studied and just followed very, very meticulously than all of these other agents, which are also proven to be safe and effective. But it just doesn't match up for me from a medical standpoint when we're saying we want this alternative compared to vaccination.
And unfortunately, the new medications that you spoke of outside of the monoclonal antibody, the efficacy of those is not what we previously saw with our monoclonal antibodies, ranging from 30%, 40%, 60%, and we were seeing tremendously better results out of the previous monoclonal antibodies. So it's important to realize that those are modalities that we're using for treatment. They are not as spectacular as what we've had in the past. They have very limited supply. They are somewhat complex medications to prescribe. Thank God for our pharmacists, because we say this patient is appropriate to administer to them, and then we throw the football over to the pharmacists, and they go through this complex medical history and list of medications and previous medical problems to make sure that these medications are safe to administer. So really what we would look at is the importance of understanding who those high-risk individuals are. And as Adam alluded to, there is an algorithm that is used now along with our clinical judgment on how sick the patients are and what their risk factors are. And the easiest thing to look at in dividing folks up is number one is immunosuppressed people. Immunosuppressed people, so people who are actively undergoing chemotherapy or cancer treatment, individuals who are on immunosuppressive medications for their medical conditions that make them have a not normal immune system, transplant patients, all of these types of patients that do not have normal immune systems are some of our highest risk patients. And we do encourage those patients to, if they have any suspicion that they have contracted COVID, to be seen immediately by their providers and get plugged into the system. The next category or cutoff that is also the easiest to delineate is the 75 and older crowd.
Right.
It gets a little bit sticky once we get kind of out of that, and that is in the 50 to 74-year-old range. The individuals that are in that class kind of go back to where we talked about risk factors. And so that population that is unvaccinated in that 50 to 74-year-old range that has risk factors, diabetes, chronic kidney disease, hypertension, cardiovascular disease, chronic lung disease, all of those individuals in that group that are unvaccinated, we are more concerned about because they don't have the protective effects of the vaccine, and they have risk factors that put them at a higher likelihood for developing more severe disease. So that's really the initial cutoff when we talk to folks now, because things have changed dramatically in the last few weeks. That's kind of our breakdown.
Yeah. And talking a little bit about that, age, get the question, at one time it was 65 and now it's 75. Age can be lumped in there as a medical condition risk factor because at the end of the day, we're all getting older, and the older you get, the less responsive your immune system is, and the higher risk you are for illness, disease, all of those things, fact of life. As we get older, we're more susceptible to those things. We had a question on Facebook prior to coming on live, which was about that 55 to 74 group, and why are unvaccinated individuals prioritized over vaccinated for outpatient treatment. And I'll be the first to say, I am one of the strongest vaccine advocates around. I'll argue with anybody that is absolutely number one is what we should all do to protect ourselves, to protect our community, every step of the way. But at the end of the day, we are the medical center for this community and surrounding communities, and we have to look at it based off of caring for the people that are at the largest risk to be hospitalized. And that is the group that's largest to be hospitalized. So if you're in that 55 to 74 and you're vaccinated and say, hey, why not me? You have protection already on board, whereas that group doesn't. So it's not that it's being a prioritized or favoritism towards an unvaccinated group. It's honestly that they're at higher risk for hospitalization and ultimately death. So be thankful you're in the other bucket.
Absolutely. So that, again, another plug to get vaccinated if you're not vaccinated, get boosted if you haven't been boosted. Many people that are asking me clinically nowadays about that is, well, if I'm going to get it, despite all this, why am I getting the vaccine? And it speaks to exactly what Adam was talking to, which is the severity of the illness. Right. Many, in fact, the majority of the patients that I have had that have contracted COVID over the course of the past few weeks have had very mild illness. And presumably a lot of that is because it is not as virulent, not as lethal, but also because we have such a higher percentage now that's vaccinated compared to previously. So a lot of things are working in our favor. The frustrations to those that are in the community right now go back to getting tested, testing availability, and then if that's the case and they need treatment, the availability of those resources. So we would ask folks to be patient with our staff, with our facilities, because really we're very fortunate. I have individual colleagues that I have spoken with in Terre Haute and Evansville and the Bloomington areas. Testing in Terre Haute as recently as a few days ago was 5 days off. If you called and you wanted tested, they were 5 days out. That doesn't really do us much good as far as diagnosis and treatment. Bloomington was in a similar situation, about 2 to 3 days out for testing for that. So we're really doing well locally, although compared with a year ago, the available resources has become considerably more challenging. As far as the pediatric population and the pregnant population, also important to wrap them into this, because the pregnant population initially was thought of as not terribly concerning for severe illness, but what we saw going into the fall and now what we're seeing going through the winter months is that population is definitely for concern and certainly should be vaccinated.
Yeah, your pregnant population fall into that immunocompromised group, because while going through your pregnancy, a lot of changes to your body, your immune system is inherently weakened. And then in our pediatric child population, the emergence of this new variant, high transmissibility, obviously schools going back to in-person session in this area. We've seen a lot of transmission amongst kids. Immediate thought is, this presents kind of like common cold. What am I worried about? Well, again, what am I worried about is that the MSIC, which is the multi-system inflammatory illness similar to sepsis in adults, is growing in percentage of children that are being impacted by that. So even if that's a small percent of children that are highly affected by that, we have individuals in this country that die every year from the common cold. And we're not scared of that. But if you're a family member of one of those individuals, or you're that individual, there's a lot of, I wish I would have taken care of myself, and we're just trying to stay out of that bucket.
And the other thing that is somewhat unique this year versus last year was we didn't see much of a cold and flu season last year because of all the precautions, because of all the restrictions. And this year we are seeing cold and flu. So in the last week or so within our ambulatory clinic, multiple flu A's, a few scattered flu B's, plenty of normal childhood illnesses that are viral upper respiratory infections. So again, we tell people that the common sense about paying attention to your symptoms, your family member symptoms, is one of the most important things. Yes, this can absolutely present as common cold, but it's important to realize that if that is happening, you should isolate yourselves. You should do the normal things that we would suggest as far as decongestants and analgesics and medicines for fever, and remove yourself from your work environment, remove yourself from school, and then determine where that illness is going. The majority of viral upper respiratory infections that we see will peak on day 2 and will be resolving by day 3 or 4 with very minimal symptoms. Strep throat is out there again right now. We're seeing a variety of other viral pediatric illnesses. So contact your providers, primary care, our convenient care facilities, and get in and get an appropriate diagnosis, and that way we can help people understand where they need to go from there.
One point that you made that's so important, and let's just make it clear that it's here to stay likely forever, is that if you have symptoms of illness, runny nose, cough, headache that is abnormal, certainly fever, then you should stay home from work, or you should stay out of school. The days that we grew up in of suck it up and go to school, or suck it up and go to work, are really gone. We need to be conscientious of those that we're being around and are potentially putting at risk. And certainly this newer variant has shined a light on that, because if you are around people in an enclosed space, not masking and taking appropriate precautions, you will get someone else sick. And nobody wants that feeling of I impacted somebody else by my actions. So if there's one thing to take away from that, is that in all likelihood, I believe that's probably here to stay forever, is that we're more aware of our symptoms, and as we're having those symptoms, knowing that, okay, I need to stay home, I need to take precaution. And if you don't want to come to convenient care or your doctor, home tests are a great avenue for that. So talking a little bit about home tests, and certainly there's been a nationwide push in the hundreds of millions of home tests pushed out there, and how can those be used versus how can they not. We don't use them for medical decision making in a healthcare setting like treatment. But absolutely, if you have symptoms and not sure if you should go to work, not sure if your child should go to school, home tests are a valuable resource to have a couple kits in your home and do that test and check.
And it's important to realize that these tests, the majority of the home tests that people are using now, are the exact same antigen-based tests that we have used over the course of the past year. So the test itself is very accurate. The methodology for collecting it is usually the big variant. And the other thing that's variable is how quickly you test after your symptom onset. So a good utilization of tests, Adam had mentioned that perhaps having a few tests at home is a good idea, which I certainly agree with. If you have a family member that develops upper respiratory symptoms, they have fever, they don't feel well, that next day is a perfectly reasonable time to do a home-based antigen test. And if it's positive, you don't really need to test the entire rest of the family over the course of the next week if and when they develop those symptoms, because you know what basically has happened. So we need to be conscious of although the government is talking about sending out all of these tests and all this home availability tests, we should be smart about it. If you're negative on one day, you probably don't need to retest the next day. And you probably don't need to retest the next day and the next day. And certainly there is no utility, and I tested positive last week, and I want to make sure that I'm cured, and I'm going to test now to make sure my test is negative. Absolutely no utility in that either. So we want you to be wise with your resources as you accumulate those home tests, just as we are being wise with the resources that we have available as well. One of the things that, of course, everybody would want us to do is predict the future. So putting us on the spot here, pandemic, endemic, dundemic, what are we kind of looking at over the course of the next year, 2 years, 10 years? And I think the thought is that as we see continued progression, new variants and so forth, and hopefully continued less virulence, that probably this is going to become seasonal like we see with influenza and stomach flu, gastroenteritis, RSV. Your thoughts?
Yeah, I completely agree. I mean, when we hear emergence of new variant, there's a pause for caution and what's the transmissibility, what's the virulence, what's the vaccine efficacy, and certainly we want to evaluate all of those things. But as we have seen this progression, even though new variants aren't necessarily a good thing, we are moving in a direction towards this is becoming more endemic and looking at this being more seasonality, flu-like. A bold prediction a year down the road is our flu vaccine and COVID vaccine are probably combined into
Sure.
one vaccine. And I was talking to an individual the other day who thought that was, how could you do that? And didn't realize that, a decade or so ago, the flu vaccine that they had was trivalent. It is now quadrivalent, and there is a new strain of flu vaccine that is put in there to protect against a different type of flu. So it's not uncommon by any means. Many vaccines are a combination of multi viral protections. So I certainly think we're moving in that direction. But the cautionary aspect is we're not there yet. People are still at risk, and our healthcare team, shout out to them. There are people working in different areas every day that they are having to get trained up on doing to provide care. Certainly this is not all COVID, but it is a dramatic COVID impact. Healthcare has been rocked by this pandemic, and the staff that are still here taking care of patients every day in these acute settings, not just at Good Sam, across the nation, really continue to be the heroes that they were recognized coming up on 2 years ago now, and are doing everything to take care of people. And it's very frustrating, may not be the right word, but maybe a little bit demoralizing that 90% of the people that we are taking care of is preventative, that they could stay out of the hospital.
Absolutely, and it's our workers have done such an amazing job in sustaining through the marathon, and are now signing up for the next marathon and the next marathon. So we send a shout out to all of them and all of the people who have been helping out and volunteering to help out with the circumstances surrounding this. But as Adam said, it's difficult for us. One of the most challenging things that we find in medicine is when we feel somewhat helpless to change things. And when we see the majority of the inpatients that we have, greater than 90%, those patients on critical care and those patients on ventilators are almost always unilaterally non-vaccinated. That's really the thing that we know that you as our population can impact. So we would beg of you, please go out, get your vaccine, get your boosters, get up to date on those things, because that's helping you, that's helping us, that's helping our medical community and our staff to sustain as we continue to move through this. So typical cold and flu season we see coming up in the holiday season, running through January, February, improving as we get into March. And we would anticipate that that will be the same thing this year. That being said, realize that some of the things that you may be contracting right now aren't COVID. And we do have effective treatments for those other things, including influenza. We have medications that treat that. It requires a quick diagnosis and quick treatment. Same thing with streptococcus and also the other things that we see respiratory-wise, including pneumonia. So we are still seeing all the normal things that we would see. We are still seeing heart attacks and appendicitis and gallbladder disease and delivering babies. So we want to make sure that we have all the resources available to do those things. And we would ask people to stay plugged in with their primary care so we can get you the appropriate treatment at the appropriate time.
Yes, certainly not a time to delay care in any facet. If care is needed, we're here to deliver it. We're not limiting care. Certainly there are some areas that have been struck pretty hard by COVID and have had to do that to respond appropriately. But it has been a key commitment of ours since day one to continue to provide services for our entire community for all of the care that's needed to be delivered.
And I've had a lot of patients recently ask me with regards to elective procedures and what we're doing. We have no intention, if at all possible, to limit care as far as procedures that people need to have done. After the initial onset in spring and early summer of 2020, when things got shut down, we've learned the hard lesson that unfortunately everything is going to continue to happen just as it normally would, and we want that continuation of care so patients can get the things done that they need to have done. So as we proceed through this most recent spike and out of the spring and into the summer, we want to continue to offer all of that normal care, including elective procedures that we would always offer.
Yep.
Other hot topics before we move on to questions?
I don't believe so. Let's see what kind of questions we've got.
Valerie.
We have a couple today. The first one, are the booster vaccines being billed to insurance, or are they done like the original vaccines?
Booster vaccines are the same as the initial vaccine series that is still being provided through the federal government. That is ran through your insurance if you have insurance, because all insurances, whether a federal program, Medicare, Medicaid, or a insurance through your employer, have agreed to pay a certain amount for that. But anybody who does not have insurance, or your insurance isn't covering it, which again, that shouldn't be the case, there is a backup that the federal government is covering that. So end of the day, I think the answer you're looking for is that there is no out-of-pocket charge to any individual getting vaccinated. The same would be true for our treatment options, that we're able to provide those in the same pathway. So there's charges that you may see on your explanation of benefits to an insurance, but those will be covered through these programs.
Okay. The next one says, I apologize if you've already addressed this, but I've heard that at home testing, results are often false positives. Any truth to that?
Sure. So great question about home testing. How accurate are the tests? False positive, false negatives. As we spoke about before, the big thing is that the tests themselves are very accurate. These are the same type of antigen-based tests that we used over the course of the past year. And internally and then also through the studies, those have proven to be very accurate. The keys are really the timing of that testing and then also the sampling associated with that testing. So if you take your swab and you wave it out here in the air and you don't actually get it into your nasopharyngeal cavity, it's not as accurate. So the sampling is very important. Thank God you can learn to do everything on YouTube nowadays. Unclog your toilet, take your shotgun apart, and nicely sample your nasal mucosa. So please look up the appropriate sampling of that on the internet, and it will demonstrate you how to do that. And then the other thing is the operation of the test. These are not difficult. The instructions are right there. The solutions are right there. But the thing that a lot of times people just don't understand is if I think I may be developing symptoms right now, I'm not sure, and I test immediately, the accuracy is not nearly as good as if you have developed symptoms and tomorrow you say, yeah, boy, I had a little nasal congestion yesterday. Today, my head is extremely full. I have a headache. I have a low-grade fever. I feel kind of achy. The likelihood of you getting a positive test under those circumstances is much greater than if you had done it the day before when you maybe thought that some symptoms were coming along.
That's all we have today.
Any other things?
Okay.
Ed?
No, I don't believe so.
Very good. Thank you all for joining us. We'll be with you again for the next update, and we would ask everybody to be cautious as we move throughout the season, and all of the standard precautions that we have preached for the last couple of years almost, we would ask you to stay in place and be cognizant of yourself and also your fellow family members. Thank you. Have a good week.